Hello doctors, how are you? Today we are going to talk about very commonly used antibiotics, especially their mechanism of action. We will talk about clindamycin, erythromycin, rather full group of erythromycin and related drugs, which is macrolides, and chloramphenicol. We will mainly today our focus is about the mechanism of action of clindamycin, erythromycin and chloramphenicol. This lecture will be in 3 steps. Step number 1 is that we should understand that what are the common things in mechanism of action of these 3 drugs. Number 1, what are the common things in mechanism of action of these 3 drugs. Step number 2 is we will also learn what are important differences in their mechanism of action. And lastly, we will discuss in this lecture that related with the mechanism of action, what are the clinical implications? In clinical practice, what are the important points related with these drugs if you understand the mechanism of action exactly, right? So let's start with. Now, there are few things common. For example, if you ask someone mechanism of action of clindamycin, macrolides and chloramphenicol, right? Every doctor will say all of them are protein synthesis inhibitor, right? This is common. All of them are protein synthesis inhibitor in the susceptible bacteria, right? Number 2, all of them work on the ribosome because ribosomes are the molecular machines which synthesize the protein. Number 3, all of them work on the 50S larger subunit of the ribosomes of susceptible bacteria. Number 4, okay, I will write it down one by one. Number 1 thing, all of them are protein, yes, protein synthesis inhibitors, right? If we go into more detail, we go deeper, we know that all of them basically act on the, yes, ribosomes of susceptible bacteria. They work on ribosomes. And if you go into more detail, as we have discussed in previous lectures, that ribosomes have basically a smaller unit and larger unit. And we know that some of the antibiotics, they work on the smaller unit, which is called 30S, and some of the antibiotics mainly work on larger unit, which is called, yes, 50S, right? Now, all 3 of them, clindamycin, erythromycin or macrolides, chloramphenicol, all of them work on the larger subunit, that is 50S. Then we go into more detail that within the 50S, point number 4 is, good doctor will tell you, within the 50S, there is a special function, catalytic function, right? That 50S unit has a special, yes, enzymatic activity, right? I will show you here. This is a specific enzyme, right? And this enzyme is basically present in 50S subunit. I'm just making it a very simple diagram. Suppose this is the enzyme. Now this enzyme, right, as most of the enzymes are proteins, this enzyme is not protein. That is why actually this is not really a protein, it is one of the ribosomal RNA. What is it? It is one of the ribosomal RNA, and that RNA is basically, this is an RNA, and this ribosomal RNA is 23S unit. What is this? 23S, ribosomal RNA. This ribosomal RNA, 23S ribosomal RNA this is, yes, a part of what? It is a part of 50S subunit. Now basically, this ribosome has a special catalytic activity. It works like an enzyme. Because this ribosome, which is 23S, act as an enzyme, right? It is a very special exception that almost all enzymes are protein in nature, but this is a special catalytic component present in 50S subunit, and this catalytic component is consisting of 23S ribosomal RNA, right? Actually, all three of the drugs work on this subunit, right? Now, so a good doctor will say that all these three drugs work on the work by reducing protein synthesis in the susceptible bacteria. Actually, they work on the ribosomes of those bacteria. In those ribosomes, they especially work on 50S subunit, and within the 50S unit, they work on a special catalytic unit, which is basically 23S ribosomal RNA. Because this catalytic activity is in the ribosome, so this is called ribozyme. So what is it called? Ribozyme. Ribozyme. Right? So we can say that all three of these drugs work on the 50S subunit, right? Especially on ribozyme, which is actually 23S ribosomal RNA. Now, as I will explain within few minutes, that this ribosomal RNA, right, or this ribozyme 23S ribosomal RNA or ribozyme functionally, catalytically, basically it makes a peptide bond between the two amino acid, right? So we call it peptidyl transferase. This is also called peptidyl, yes, transferase. Peptidyl transferase. Now what you can say? We can also say that clindamycin or macrolide, which include erythromycin, with erythromycin some new macrolide which are clarithromycin, azithromycin, right, or some other also macrolide group, all of it, and chloramphenicol, all of them actually work on a peptidyl transferase. Now I will go in reverse direction. They work on peptidyl transferase, which is also called ribozyme because it consists of a 23S ribosomal subunit present in the 50S component of the ribosomes of prokaryotes, susceptible prokaryotes, and inhibit their protein synthesis. Now, up to now, everything is common, right? That all three of the drugs work, all these 6 steps or points are common. All of them are protein synthesis inhibitors, all of them work on the susceptible bacteria ribosome, all of them act on the 50S subunit, all of them act on the 50S subunit special point, which is 23S ribosomal RNA, which is also called ribozyme, and which is functionally peptidyl transferase. Now, very briefly, I will explain there how the peptidyl transferase work. How the peptidyl transferase work. Very briefly, I will explain it, right? Then I will explain all of these drugs are working on peptidyl transferase, but their action is little different. And if you become clear about that, then you will be able to understand that clinically why these drugs have competitive inhibition For example, if you have given the patient clindamycin, after that you add erythromycin, erythromycin will not work well. Or if you have previously given the patient erythromycin and still erythromycin is present in the patient and you add clindamycin for more action, you will not get the more action, because as I will explain, all three of these drugs, clindamycin, macrolides and chloramphenicol, there is no clinical situation in which all of them are given together, right? Because mechanism of action is such that they inhibit the action of each other. We will see, I will explain in detail. And with that, you will also understand what is post-antibiotic effect. I will explain what is that. We will also understand how these drugs can produce cross resistance. For example, if a staphylococcus is resistant to erythromycin, right, due to ribosomal alteration, target erythromycin target domain in the ribosome is altered, we will see that in such bacteria, on such bacteria, even clindamycin will fail. Or if ribosomal alteration is such that clindamycin cannot work on bacteria, right? Clindamycin has developed resistance due to ribosomal 50S subunit alteration. I will explain what kind of alteration. If bacteria has done that alteration and if clindamycin is failing, we will understand then why erythromycin will also fail, right? So let's first of all understand peptidyl transferase, what it is doing. So I will draw it here. This is 30S subunit, right? What is this? 50S subunit. And as I have explained previously that this area is called A site, this area is called P site and this is called E site. And here is a special tunnel going out which is called exit tunnel, right? Now, this is 30S unit, that is 50S unit, and here is your messenger RNA, 3' end and 5' end we put it here, 5' end, and this is tail end which is also called 3' end. This is messenger RNA and these are your codons, right? Now, I'm going to just remember why we call it is A site and why we call it P site. Actually, here is the transfer RNA which is carrying what? It is carrying, yes, recently formed oligopeptide, which is also called nascent polypeptide chain, right? This is being formed. For example, this is amino acid number 1, this is amino acid number 2, this is 3, this is 4th, and now there is incoming amino acid on this transfer RNA and this is new amino acid, right? And this transfer RNA, where if with these messenger RNA codons, anticodon will be complementary and it will be carrying an amino acid. Now, this amino acid and this peptide chain, they should be connected with each other. An enzyme will connect them that will help to elongate this chain. That will be the first step. If we connect this, that we are doing transpeptidation, because there is transpeptidase. What that enzyme is doing here? Okay, I will remove these. You just remember on A site we have amino acyl transfer RNA or incoming new transfer RNA with a new amino acid. At P site, what is there? Okay, I will put it here, A site, this is P site and this is E. At P site we have transfer RNA which is carrying the short peptide chain, right? Nascently formed polypeptide, right? And A site, P site, E site is from where eventually the transfer RNA which has given up its, what is this, amino acid, that will exit. So this is, now what is and where is your ribozyme? Actually here is your ribozyme, right? And this is basically, come back here, ribozyme, which is structurally consisting of 23S ribosomal RNA of the 50S subunit of the bacterial ribosome, and functionally this ribozyme is peptidyl transferase. We are now going to focus how this ribozyme or 23S ribosomal RNA or peptidyl transferase, how it works normally and how these drugs inhibit. Just look at it, what it is. This is now ribozyme, and this ribozyme, okay, this is ribozyme. I will draw it here just to explain it clearly. This is ribozyme, right? Now it has two special domain. One domain is going to work now here. One domain is going to work on amino acid transfer RNA. Other domain is, functional domain is working on short peptide chain. Now this is our what? 23S ribosomal RNA or ribozyme or peptidyl transferase, how it is working. Okay, if I am the peptidyl transferase, I am having one, this side, suppose this is the domain, functional domain, which is attaching with the, what is this, incoming new transfer RNA with a new amino acid. We call it peptide, we call it amino acyl transfer RNA. And other domain which is attached with the transfer RNA, which is carrying the short peptide chain, which is recently formed nascent peptide oligopeptide unit. This domain is working in which area? Yes, in P site, and this is working on A site, right? Now we can say, if I am the, okay, if I am the peptidyl transferase, my this unit is working on amino acyl transferase, amino acyl transfer RNA, and my this unit is working on peptidyl transfer RNA. So this unit is mainly working on A site and this is mainly working on P site. Now, what is the function of these two domains? What is the function of these two domains? The function of these two domains is that they will orient these amino acids in such a way, yes, that they help in formation of a peptide bond between newcoming amino acid and oligopeptide chain. So this will lead to the formation of a, what is this, peptide bond. So what it has done, there was one this side, so this chain, oligopeptide chain or recently formed peptide chain and the new incoming amino acid, they are oriented with each other and they are connected with each other, right? When this bond is formed, this is one function, this is only one function which peptidyl transferase is doing, which a ribozyme is doing, which 23S subunit is doing. This is one function. Second function it will do that once preformed chain and the new amino acid are connected, then this will dislodge it from, what is this? From which transfer RNA? Peptidyl transfer RNA. This chain will be dislodged. Okay, I will draw it separately so it becomes more clear to you. So there was a short chain, right? And this was new amino acid. First of all, this enzyme, ribozyme, it made a bond between them. Now, what happened? Amino acid number 1, 2, 3 and 4, they were already part of the chain. Now, fifth new amino acid or fifth amino acid also connected with the chain. After that, it will dislodge the chain from transfer RNA present in P site. It will dislodge. When it will dislodge, this chain will be transferred at transfer RNA of amino acid position. So what will happen, that this whole chain will transfer actually there, and you will see how we can show that from here chain has been transferred there. So second work is, now 4 number amino acid is here. I will again make it more clear. There is a bond between them. There is a bond, then 4 number, then bond, then 3 number, then suppose 2 number, then 1 number. Now this chain from here has been transferred to the new amino acid. That is why it is called peptidyl transferase. It has transferred the short peptide chain and the new amino acid. Step number 1, peptidyl transferase or ribozyme will make a bond between these two. And after that, this chain will be transferred there. So this has done peptidyl transferase activity, which had two components. Number 1, peptide bond formation between short peptide chain and the new amino acid. And second function which has done, once this bond is formed, it will evulse, it will detach, it will remove this chain and transfer it to the new point. After that, so what have happened up to now? Number 1, this process is called transpeptidation. What is it called? Transpeptidation. Once transpeptidation has been done, after that, this complex, what is this? Ribosomal unit 30S and 50S, they will move one step towards the 3S subunit, and they will move, this whole complex of ribosome will move one codon down the messenger RNA towards its 3 end. And this movement of that is called translocation. Translocation. And once ribosomal translocation. When ribosomal translocation has happened, then what will happen? That when ribosome have moved there, then actually this will shift to P site, and this previously aminoacyl transfer RNA which had received a short peptide chain, this, because ribosome have moved one step ahead, it will come in P area, right? And it will convert into peptidyl, this will convert into peptidyl transfer RNA. And because peptide chain has been transferred to that, this RNA will come to exit site and eventually fall out, right? And because this has shifted over here, so this area will become empty. What I want to say, that very briefly, that 30S and 50S, after translocation, what will happen? After translocation, when it has gone one step down, that messenger RNA with short peptide from here has come over here, and this area is empty, and there is the transfer RNA which was having short peptide chain, right? That has come over here, 5 amino acid, right? And which was previously here, this has moved into exit place, empty place, and A site is empty for the upcoming another amino acid or another transfer RNA with a new amino acid or new aminoacyl transfer RNA will come here, and this cycle will repeatedly go. So step by step, codon by codon, amino acid by amino acid, peptide chain will be elongated, right? So to add one amino acid, one cycle is completed. This molecular cycle is, first of all, to add one amino acid, new amino acid transfer RNA come to A site, new amino acid transfer RNA come to A site. Next, peptidyl transferase makes a bond between the pre-existing short peptide chain amino acid bond with the new amino acid, right? After that, detach the short peptide chain from the peptidyl transfer RNA and transfer this peptide chain to the new amino acid, right? So this has done transpeptidation. After that, ribosomal translocation one step down, and this will eventually come to this side and exit out, and this one will come over here, and this will be empty for the next upcoming. So this cycle will be repeated again and again. Transpeptidation and then translocation, ribosomal translocation. Transpeptidation followed by ribosomal translocation, and every time this cycle is repeated, chain will be elongated, peptide chain will be elongated by one amino acid. So this is said to be peptide chain elongation. Now listen, what really happens? All three of these drugs, up to now the things are common. All three of these drugs, clindamycin, all macrolides and chloramphenicol, all of them basically produce dysfunction in peptidyl transferase activity and translocation activity. Again I will repeat. All three of them, first, this is the last common step. After that, I will tell you how these drugs differ in their mechanism of action. But all of them up to now have everything common. All of these drugs basically act on the 50S subunit. They basically act on 50S subunit. Which point? At the ribozyme, which is 23S subunit. All these drugs bind over here and they disrupt the function of what is this? Peptidyl transferase. When peptidyl transferase is not working, then peptide bond is not formed, peptide chain is not shifted to the new, and then ribosome does not translocate. If transpeptidation is not done, the next step, translocation fail. When transpeptidation and translocation fail, chain will not be elongated. So a good doctor, very good doctor will say that all these drugs, clindamycins, macrolide like erythromycin, clarithromycin, azithromycin and chloramphenicol, which is not macrolide, all these drugs basically inhibit the protein synthesis by inhibiting the early chain elongation process. All these drugs, what they are doing? Up to now, the common thing, clindamycin, macrolides and chloramphenicol, all of them, when they are working on the susceptible bacteria, they reduce the protein synthesis. How they reduce the protein synthesis? By disrupting the functions of prokaryotic ribosomes in susceptible bacteria. Where in the ribosome they work on the bigger subunit, which is 50S subunit. On the 50S subunit, exactly where they work on the 23S ribosomal RNA, which is having enzymatic activity, that is why that is also called ribozyme, and that enzymatic activity is peptide bond formation and peptide chain transfer. So that is why enzymatic activity of 23S RNA or ribozyme is functionally, catalytically, it is peptidyl transferase activity. If peptidyl transferase is done, function is done properly, only then what will happen? When transpeptidation is done, only then translocation will occur, right? Only then translocation will occur. Now, all of these drugs basically inhibit the function of peptidyl transferase primarily. So we can say they inhibit the function of, what is this common? Chain elongation. All of them eventually inhibit transpeptidation and plus okay, I will write it here, translocation, right? Due to this result, what will happen? what will be reduced eventually? If transpeptidation is reduced and translocation is reduced, that will result into what? Okay, if transpeptidation is reduced, automatically translocation will be not done. If translocation fails, that will lead to point number 10. Early chain elongation is fail. Early chain elongation fails. And if early chain elongation fail, then protein synthesis will be inhibited. So 10 points are common in their action. All these three group of drugs, clindamycin, macrolides and chloramphenicol, they have 10 points common. After that I am coming to differences. What are 10 points common? All of them reduce protein synthesis by susceptible bacteria, by acting on the ribosome, especially on the 50S larger subunit. To be very specific, on 23S ribosomal RNA, which is also called ribozyme due to its catalytic activity, and catalytic activity is peptidyl transferase, which is making a bond between the amino acid on acyl transferase and other amino acid on nascent peptide chain, peptidyl transferase. And if peptidyl transferase is inhibited, then transpeptidation is not done, translocation of ribosome does not occur, ribosome is unable to move on messenger RNA, unable to read it further, and eventually early chain elongation will fail, which will result into protein synthesis inhibition. If this is clear, now I will explain how these three group of antibiotics on their action, how they slightly differ. And because they slightly differ in their mechanism of action, right, in transpeptidation and translocation, that differences and that understanding will help you to understand that how these drugs produce competitive inhibition, how some of these drugs produce post-antibiotic effect, how some of these drugs lead to cross resistance. Let's go to that now. First of all, let me explain their differences, right? Let me explain, if these 10 points are clear to your mind, let me explain exactly on the ribozyme how these drugs work, right? Now I will make a simple diagram, but I will make 3 diagrams. In one diagram, first diagram, I will show the action of clindamycin, right? And in second diagram, I will show the action of macrolides. In third diagram, I will show the action of chloramphenicol, and you will become crystal clear about their function, their mechanism of action and their differences also. So let's suppose clindamycin action first of all. This is 30S, yes, this is 50S, right? And how in A site we have what? Five prime and 3 prime. And A site we have amino acyl transfer RNA. At P side we are having, what is this? Peptidyl transfer RNA, right? And here are your actually codons. Okay. Now here is what? Now you will tell me, what is it? This is peptidyl transferase. Molecular structure, what it is? 23S ribosomal RNA, or we call it ribozyme, this green, or we call it peptidyl transferase. And normally how it works? It has 2 domains. One domain has to work here, another domain has to work on that. Now, clindamycin, remember, clindamycin is Linda. Linda is what? Linda means a beautiful girl. Clindamycin is a beautiful girl. right? Now, this beautiful girl, clindamycin, how does it work? It actually attaches with, this is a beautiful girl, clindamycin. Yes, what are these? Okay, these are her very silky hair. And she is, yes, she is sitting on, okay, she is sitting on what? 50S ribosome component, functional component, which is 23S ribosome. And she is sitting over here, and her legs, one leg is going towards which side? P side. And other leg is going towards A side, right? And if clindamycin binds on the 50S subunit of ribosomes of susceptible bacteria, then clindamycin, like a beautiful girl, will sit on the top of, what is this? Ribozyme, peptidyl transfer RNA. Clindamycin, Clinda, easy way to remember, Linda, beautiful girl. She will sit over here, and she has long, beautiful, graceful legs. And these legs, she will push it down, and now she has, do you think peptidyl transferase, it has, you remember it was having two, what was this? Domain. One domain was supposed to work on A side, and other domain was supposed to work on P side. First was supposed to work on amino acid transfer RNA on the new, and other was supposed to work on peptidyl transfer RNA. And if it was able to interact properly, only then this will make a bond. Now, clindamycin is sitting like that. If it is sitting at the top, right, this is what? So it was having two functional unit. One was for the binding with the new, what was this? And other was binding with other. Now, if Linda sits over here, this will push its to this drug active component will actually interfere with what? They will extend to A site and P site, and now these active units are not able to work on their substrates. These were the substrates, right, over which it worked. These are the substrates where this could work and make a what? Make a peptide bond, and then transpeptidation. If clindamycin, like a beautiful girl, sitting on the top of, what is this? Ribozyme, right? And it inserts its legs, active domains, its active domain of the drug, they are inserted over here. Do you think now transpeptidation can occur? No. If this bond cannot form, peptide chain cannot be transferred, it means clindamycin led to the failure of transpeptidation. And if transpeptidation has not occurred, of course you understand what is the other thing which will fail? Translocation. And if clindamycin is binding with peptidyl transferase or 23S ribosomal RNA or with the ribozyme, if it binds in such a way that it actively disturb the A site and P site in such a way that these substrates cannot work with the catalytic units. So transpeptidation will fail, then subsequently translocation will fail, and eventually chain elongation will fail. And if chains cannot be elongated, how proteins will be formed? So what will happen? Number one, protein synthesis will be reduced, and if any proteins are produced, they will be distorted. They will not be having the complete amino acid set. So we say this is how exactly clindamycin leads to what? Protein synthesis inhibition, right? And that results in bacterial proteins which are reduced and reduced in amount, there is quantitative problem. Along with that, there is qualitative problem, and whatever they are produced, they are not working well, right? And that leads to many effects. One of the effects is that bacteria is now unable to produce proteins to multiply. So bacteria is unable to multiply. Then what will happen? We will say clindamycin is acting as a bacteriostatic drug. That drug is lead to the inhibition of proliferation or multiplication of the bacteria. But if dose is higher, if clindamycin concentration is higher, then on some of the bacteria, it inhibits not only those proteins which are required for bacterial proliferation, this also inhibits those proteins which are required for survival of the bacteria, and such drastic action may lead to bactericidal action. So generally speaking, protein synthesis inhibitors are considered bacteriostatic. But if clindamycin is in some bacteria in heavier doses, it can lead to even bacteriocidal action. Now here I will tell you one more thing. When clindamycin is working like this, bacteria are unable to produce proteins. Let's suppose we are giving this. Now listen carefully. Let's suppose if clindamycin is given to a patient who is having toxic shock syndrome, toxin. Now what is toxic shock syndrome toxin? Let's come here. Suppose this is a special variant of Staph aureus. Now this Staph aureus can produce a toxin which is called toxic shock syndrome toxin. Now this toxic shock syndrome toxin actually is commonly produced by some strains of Staphylococci and some strains of Streptococci. And these toxins, toxic shock syndrome toxin, this toxin is basically what is this toxin? This is a superantigen. Superantigen is an antigen produced by a bacteria. Here, in our example, toxic shock syndrome toxin is superantigen. What is superantigen? Superantigen is basically a type of antigen which can activate massively our immune system. They will activate many unrelated clones of T cells, and those T cells will activate lot of immune system activity. So superantigens, I will explain in some later lecture that superantigens basically act on the antigen presenting cell like macrophages and on the T helper cell, and non-specifically activate them, right? And when lot of, for example, if in my body such Staphylococci or Streptococcus is present and this is able to produce toxic shock syndrome toxin, then what will happen? That this toxin will activate many of my macrophages and T helper cell, and this massive inappropriate activation of the immune system will produce massive concentrations of cytokines, and those cytokines will eventually lead to shock, cardiovascular collapse, right, with multi-organ failures, right? And we say this superantigen or toxic shock syndrome toxin is basically has produced massive inappropriate activation of the immune system, resulting into massive productions of cytokines which eventually lead to multi-organ failure and cardiovascular collapse, and patient may die in a very short time. Now toxins are this is exotoxin. This superantigen or exotoxin is basically a protein, and we see that clindamycin can on the susceptible bacteria, not only it is bacteriostatic or bactericidal, even it can reduce the production of toxins. If patient is suffering from toxic shock syndrome, or you are expecting patient is going into that condition, along with beta-lactamases or vancomycin, we must give clindamycin at least for first 48 to 72 hours, and this clindamycin will specially work on reducing toxin production by inhibiting the protein synthesis, right, and prevent the patient from disastrous multi-organ failure. This decision that in a patient with staphylococci or streptococci where you suspect patient is going into toxic shock syndrome, please add clindamycin along with the beta-lactam antibiotics or vancomycin, so that while beta-lactams are killing the bacteria, at least clindamycin immediately start reducing the production of toxins, and inappropriate massive activation of immune cell is reduced and toxin production is reduced and multi-organ failure is eventually prevented. So this decision to use clindamycin can be life-saving in the patients with toxic shock syndrome problem. This is one thing. Secondly, another toxin, I give you example. Some of the staphylococci, they produce a very, very dangerous toxin, and this toxin is called alpha toxin, right? Some staphylococci can produce alpha toxin, then streptococci can produce, then Clostridium. What is another Clostridium which produces very dangerous toxin? Perfringens. Now, if you are having such kind of Staphylococcus or Streptococcus or Clostridium perfringens which is able to produce very destructive tissue damaging toxins like alpha toxin, which dissolve into our membrane, tissue membrane, and cell membranes are perforated, because alpha toxin which is produced by staphylococci specifically, alpha toxin if are produced, they act on our cell membranes and produce membrane will have multiple pores, right? And when membranes are massively disrupted, that may end up into necrotizing fasciitis or gas gangrene. Necrotizing fasciitis or gas gangrene, both of them, if not rapidly managed, are very, very dangerous diseases which can be fatal. And in this condition also, in such condition also, we, along with other antibiotics, we can use clindamycin to inhibit the production of alpha toxins, so that necrotizing fasciitis or gas gangrene progression is reduced, right? So by this action, what I have told you, that clindamycin is very important in reducing the reducing the toxin production. And for example, which toxins? Toxic shock syndrome toxin and alpha toxin by staphylococci. Is that clear? So this was one clinical correlate. Now we come to,
is there any role of penicillins in this alpha toxin situation?
yeah, this is very big problem. You asked very well, very good question, that if we are giving beta lactams which are able to kill the bacteria, right, or we are giving vancomycin, or we are giving some other drug, right, which is related in killing the bacteria, but if you don't give, now listen very carefully, if I'm the patient who is having necrotizing fasciitis, let's suppose due to very dangerous strain of staphylococcus, and the staphylococcus which I am having, that is producing alpha toxins, and that is producing necrotizing fasciitis, rapidly spreading muscular compartment gangrene and tissue damage and fascia damage, right? Now, this is very important clinical point which I am going to elaborate. You already understand, if we give clindamycin, that will inhibit the production of alpha toxin. But there is another thing. If you don't give clindamycin, of course, production of toxins will not be reduced. But if you are giving beta lactams alone, you know what beta lactams do? Very unfortunate thing. beta-lactam given alone can actually amplify the production of this toxin, alpha toxin. Or even fluoroquinolone given alone can amplify the production of alpha toxin. So, this will be very unfortunate if some good doctor in a patient of what is this necrotizing fasciitis, he gives beta-lactam antibiotics. Of course, some bacteria will be killed, but many of the bacteria before dying will produce massive amount of alpha toxins, and that will further enhance the problem. So, what we can say, this alpha toxin, right? Clindamycin inhibits its production. Beta-lactams actually increases their production, beta-lactams, and fluoroquinolones, they also moderately increase the production. But beta-lactam drastically increase the production of alpha toxin. So, it's very important that along with such drugs in necrotizing fasciitis or alpha toxin producing staphylococci infection, you must give clindamycin to reduce the production of toxins. Is it clear? Right. Now, let's go to another point. So, we have talked about that clindamycin can lead to proteins synthesis inhibition, and this protein synthesis inhibition will eventually lead to reduced proteins and distorted protein, which will result in many actions. One action I told you, it may reduce proliferation of bacteria, bacteriostatic action. In heavy doses in some bacteria it kills them, bactericidal action, and very important, one action by reducing toxin production was what? That it reduces toxin production, and this function is especially very useful in patient with toxic shock syndrome and also patient with such staphylococcal infections which produce alpha toxin. Is it clear? Now, okay, I will go in further detail of clindamycin and their action, but before I go, what do you think? I go directly to the clindamycin and further mechanism of action, or compare the three antibiotics action? I compare now, right? Then I will go into...
I wanted to know if the proteins are formed distorted, will they have any effect on the bacterial?
Yes, we will talk about that later. Let me compare and contrast the mechanism of action of these three antibiotics, right? Let's come back to our Linda, the beautiful lady. She is sitting on the top of what is this? 23S, ribosomal subunit, and with this active domain, this lady has two beautiful legs and she is kicking at A site and P site and does not allow transpeptidation and translocation, and eventually chain elongation fails, and that lead to protein synthesis inhibition. Now let's compare it with, okay, I will write it here. This was Clinda. This is clindamycin. Now let's compare it with the macrolide function. Okay, basic, we are drawing the amino acid, ribosome, 30S, 50S, and here is your messenger RNA with 5' end and 3' end, and this area is going to be A site, and this area is going to be P site, and this is E site, and here is your, what is this? Exit tunnel, and you remember that here was, what was there? Amino acid transfer RNA, and here was peptidyl transfer RNA, codon anticodon interaction, and this is new incoming what? Amino acid that was previously made chain, and here was your, what was it? Ribo. It is also, actually it is 23S ribosomal RNA, which is actually called ribozyme, but it act as a Peptidyl transferase. Now it is supposed to make a chain in a connection between the two, right? By these two domains. One domain acting here, other domain acting here, and it should make a bond. Wow. Now here macrolide come. Macrolide may be erythromycin, an example of old macrolide, and new are, I will just write down two commonly used, clarithromycin, and another new commonly used is azithromycin, right? Now, these are macrolide. How the macrolide work? Actually, macrolide also work on the same peptidyl transferase, on the same ribozyme, on the same 23S ribosomal RNA. But look here, it is the macrolide, the lady macrolide sitting over here. Right? She is sitting over here, but what she has done? She is facing to which side? P side, and her both legs are in the P side, and she is kicking there on the P side, and she puts also one hand into exit tunnel. Right? What is this? This is macrolides, erythromycin, macrolides. So look, the common thing is, now if it is, so what will happen? This area will not function, this domain will specially not function, and this, if P site domain of the peptidyl transferase is not functioning, then naturally, do you think this oligopeptide can be linked with the new amino acid? No, right? And the result will be, number one, not only, yes, this drug, what was the name of this drug? Macrolides, right? And these macrolides are also attaching to the 23S subunit like that. But they are mainly acting on the P side. They are mainly interfering with the P side. And if they are acting on the P side, what will be the result? Peptidyl transfer RNA will be, what will happen? It will be distorted at its position, and there will be failure of transpeptidation. And secondly, it is also blocking the exit tunnel. Both of these functions will lead to failure of translocation, ribosomal translocation. And if ribosomal translocation fail, chain elongation fail. And if chain elongation fail, protein synthesis fail. Right? Now, we can say that macrolide or erythromycin, even though like clindamycin, they work on the peptidyl transferase, but they mainly interfere with the P site, and also so they lead to failure of transpeptidation, and they also block the exit tunnel from where the newly found peptide chain will eventually go out. All this molecular distortions will result in failure of transpeptidation, failure of ribosomal translocation, and both these phenomena will end up into failure of protein synthesis and bacteriostatic in most cases, and in some bacteria in very high doses, these drugs, especially newer antibiotics, might produce bactericidal action. Is that right? So now you can see the difference in them, right? But let me explain action of chloramphenicol also, and then you can compare all this, right? Now we come over here. The action of chloramphenicol. What is this? 30S, here it is, 50S, your messenger RNA with 5' end, 3' end. What are these? Codons at A site and P site, which are actually, A site and P site are actually the part of 50S mainly, and here is peptidyl transferase, peptidyl transfer RNA with recently formed oligopeptide or nascent polypeptide, and here is your new RNA. Here there must be your strongman peptidyl transferase or ribozyme or 23S ribosome, and here it is attached, and its main action should be again to connect. Here another lady come and said chloramphenicol. Okay, but this time the both legs of her are on which side? A side. Both active units. Now look at it. What she will be doing now? It will be different than others. We saw clindamycin also attached with the ribozyme or peptidyl transferase, but it disturbed both A and P side clindamycin. What was this? Macrolides. They also bind with peptidyl transferase, but mainly they work on the P side and also on the exit-tunnel. Right? Then what is this? This is your chloramphenicol, and chloramphenicol, these ladies can be angry why we have not drawn the mascara. Okay, so now this lady sitting on peptidyl transferase, attaching with that, and its disruptive domain especially disrupt the function at A site where amino acyl transfer RNA come with the newly incoming amino acid. So what will happen? In the presence of chloramphenicol, A site will not function well. Amino acyl transferase will be disturbed sterically at its position, and there will be no bond formation between what? Yes, between peptidyl transfer RNA and amino acyl transfer RNA, and peptide chain transpeptidation will not be done. It means the bond between short peptide chain made and the incoming new amino acid bond will not be formed, and this will not be transferred. Of course, other things are same. You know now more than me. What will happen there? Transpeptidation fail, translocation fail, chain elongation fail. But it can, this, what was this drug? Yes, chloramphenicol. This mainly act, it also work on, attach on the, what is this? Ribozyme or peptidyl transferase, but it mainly disrupt the act on the A site, and either if amino acyl transfer RNA is already there with the new amino acid, it will disturb its steric position, or actually many times this lady will kick so much that even incoming amino acyl transfer RNA will not be allowed to come or may be kicked out. That will be kicked out. Of course, result is what? Failure of transpeptidation, failure of ribosomal translocation, failure of early chain elongation, failure of protein synthesis inhibition. Right?